Hey y'all, I'm going to be doing my presentation on diathermy. Diathermy is a modality that utilizes electromagnetic energy. It converts that energy into heat to be treating large areas of the body. So it's using conversion, so no direct contact is needed. There are a couple different settings, pulsed and continuous. Pulse is going to be a non-thermal treatment, continuous is going to be a thermal treatment. Within the machine, you have drums or capacitive plates. The drums are using inductive coils that are sending oscillations down into the deep tissues, the muscle tissues. Drums have been shown to have high conductance in muscle tissue. Capacitive plates shows that it's conducting more in adipose tissue and bone, which becomes a problem for someone who has a lot of adipose tissue and you're treating them, or if they have high water content. Once you set the patient up, you can leave them and they can be by themselves for the treatment. However, you will come back during the duration of the treatment and check for adverse effects. Be sure that they're not feeling anything they shouldn't be feeling. If it's on continuous, they may be able to feel slight heat, but if it's on pulse, they shouldn't really be feeling anything. So the therapeutic effects for this are altered cell membrane function, increased edema, metabolic rate, increased muscle elasticity, nerve conduction velocity. You're going to increase their pain threshold as well as their temperature, and then you're going to cause vasodilation. So, the indications include chronic swelling, joint stiffness, muscle guarding, chronic inflammatory pelvic disease, pain, bursitis, and inflammation. Precautions and contraindications include acute inflammation and impaired sensation, acute infection, pacemakers, metal in the area, as well as IUDs, ischemic areas, pregnancy, malignancy, wet dressings, hemorrhagic areas, as well as over the eyes or testes. You would take precaution to treat near electronic and magnetic equipment, as well as for obesity and copper-bearing IUDs. My research question was, when used correctly, is diathermy effective and safe? And is diathermy more effective used by itself or in conjunction with another treatment or modality? So the first research I looked at, the study was called Continuous Shortwave Diathermy with Exercise Reduces Pain and Improves Function in Lateral Epicondylitis for more than the sham treatment. So it was a controlled randomized trial. They had 50 participants. They had a control group and a treatment group. The control group received sham diathermy. The treatment group received real diathermy, set to a continuous setting at a frequency of 27.12 megahertz. The treatment was strengthening and stretching exercises. So the inclusion criteria to be in the study, they had to be 18 to 65 years old. They had to be diagnosed with unilateral lateral epicondylitis accompanied by pain, heat, and tenderness. They also had to not have any of these things. So they were excluded if they had a history of systemic diseases like RA, if they had fractures, dislocation, neurological deficits, or nerve root pain, if they were pregnant, if they had pathologies involving their upper extremity, if they had therapeutic treatments, including steroidal injections within the last 3 months before the treatment, and then if they were receiving pain medication or additional treatment during the study, that would also exclude them. So the resulting data was using the visual analog scale, the quick disability arm, shoulder, hand questionnaire, as well as the pneumatic grip strength dynamometer. So all of these things have their scales and questionnaires. So the visual analog scale is a scale for pain from least amount of pain to the most amount of pain. And so the patient would be able to mark where they were on that scale. And then the quick dash was an 11-item questionnaire, and it's looking at ADL's social status, like if they're able to take part in the social events they want to be taking part in, if they're able to work. It was mainly looking at their impairment, their social their participation restrictions, their social limitations, and so then the grip strength was obviously looking at their grip strength, and it was measured in pounds per square inch, so PSI. And then when you looked at the p-values between the control and the experiment group, you could see that there was a significant difference, and the improvement was lying with the real diathermy group. So if I lean away, sometimes it's kind of hard to see that. So right here, the one right here, this one is the sham, this one is the real. So the bottom one is showing grip strength. So the strength for the real diathermy group had a clear improvement throughout the study. These dots represent the evals that happened. The first one is before, the second one is after the 5th session, the third one is after the 10th session, and then the follow-up is 3 months, I believe, after the study. So they had 10 sessions total, and they had the post-study evaluation. So you can see that with the grip strength. The one on the over there, that one is the VAS, so that's for pain. You can see that the darker line is the real treatment. It went down more than the sham treatment. And then you can see on this side the dash, so that's talking about their impairment and their ability to function. It was their impairment was going down, so they were able to do more things if they were receiving the real diathermy, along with the strength and stretch. So the takeaway here is that real shortwave diathermy, when used with strength and stretch exercises, did significantly help in patients with chronic lateral epicondylitis in this study. Okay, the limitations of this study, they didn't take into consideration cognitive status in terms of stress, anxiety, depression, which can obviously affect the outcomes. They didn't limit occupation and outside activities, and they didn't do manual therapy, which they mentioned that in the study as something that they would want to do in the future. And this says no conflict of interest right there. So research number 2 was called Effectiveness of Manual Therapy or Pulse Shortwave Diathermy in addition to advice and exercise for neck disorders. It was a pragmatic, randomized, controlled study. It was involving 15 PT clinic locations, and it involved 55 physical therapists that came up with the protocol that was followed for the exercise advice, plus the manual therapy and the shortwave diathermy. So I'm going to just kind of skip through this, just so you know, just to overview it. There was 3 groups. All of them received exercise and advice, and then the second group received manual therapy. The third group received pulse shortwave diathermy in addition to the exercise and advice. So all of these treatments were about 20-minute sessions, and there were 8 sessions for 20 minutes, and it took place over 6 weeks. So when you look at the amount of time spent with the exercise and advice, it does kind of, when you're only receiving that, then you probably had more time receiving that, and then if you're receiving the modality, then they had to take some of that time to do that. They were sent home with home exercise programs, and they did have pamphlets to do follow-ups to make sure they were following their home exercise programs, which was probably helpful. Okay, the inclusion and exclusion criteria: they had to be 18 years or older, they had to be diagnosed by a general practitioner with nonspecific neck pain, which meant they were having pain and stiffness in the neck, and unilateral pain down the arm, peripheralization, or no pain down the arm. So they were excluded from the study if they had red flags, which were fever, neurological symptoms, weight loss, loss of sensation, muscle weakness, malignancy, arthritis, polymyalgia rheumatica, osteoporosis. If they had major problems structurally, if they had received care 6 months prior to the study, if they were taking anticoagulants, if they were pregnant, and if they were receiving workers' comp, they were not included in the study. So the resulting data was done when you were looking at the Northwick Park scores as well as short form 12 scores. As well as these other scales that seemed to cater to the study. They weren't like something you could look up and find a form. I'm pretty sure they were just questions that they were asking them and then scaling them. And those were all in the data as well. However, these are the 2 ones that you can find online and see exactly how they did them. And so the Northwick Park score is a questionnaire that is mainly for neck pain. So you're looking at the patient and you're asking them questions. It has 10 sections on it. It's talking about the intensity of pain, the duration of pain, their sleep, if they're able to sleep, or if they're having disturbing pain, if they're able to carry bags of a reasonable weight, and et cetera, et cetera. And so that's mainly pain. The short form 12 is looking at many different areas, those being, let me remember what they are. Those are basically looking at, it was like your mental health, your physical health, if you're able to do the things you want to do. One of them was vitality. It's talking about their energy levels, if they have the energy to do what they want to do. And so basically the average of this, they find an average for an age group, and then if you are average, that means you're at 0 on the scale. If you're below average, then you go into the negative. If you're above average, then you go into the positive numbers. In the end, utilizing these scales and questionnaires, they found that neither the shortwave diathermy or the manual therapy provided any significant benefit. So the p-values for the differences were all greater than 0.05, meaning they couldn't find any correlation of like one of the therapy or of the manual therapy or of the diathermy helping the patients, and then they compared to the exercise and advice group. So in the end, we found pulsed shortwave diathermy when used with exercise and device did not prove effective in decreasing pain and helping with function in patients with nonspecific neck pain in the study over a period of 6 weeks or even 6 months post-study. So the positives, they had a high percentage of follow-up during this that 6-month follow-up questionnaire and evaluation. There was I think they had 93% that followed up. But the limitations was there was no control group, as well as a limitation that I found personally. I thought maybe if they subgrouped patients into what their response to treatment was or what their specific symptoms was, perhaps they could have gotten more clear results. And there were no conflicts of interest with this study. The third study was a double-blinded randomized placebo-controlled trial. It was called Effectiveness of Shortwave Diathermy for SIS, Subacromial Impingement Syndrome, and it was and then they were looking at the value of night pain for patient selection. So they had two main groups. They had people with night pain and people without night pain. People with night pain were divided randomly into receiving a sham or a real diathermy treatment. Same for the night pain negative patients. They received sham or shortwave diathermy treatment. So the inclusion criteria was that they had a positive subacromial injection test. They were injected, and if they had an improvement of 80%, so they increased their range of motion, except their pain went down, then they were positive, and they were included in the study, and then they had to give their written consent. And then these are all exclusion criteria if they had other shoulder pathologies like adhesive capsulitis, if they had previous therapy or injections, if they had cervical pain or other conditions like fibromyalgia, if they had malignancy, or if they had neurological, motor, and or sensory deficits in their upper extremity, if they were pregnant, if they had open wound in the shoulder area, if they had a pacemaker, or if they had allergies to a local anesthetic. So here is the evaluation. This is for the SDQ, which is Shoulder Disability Questionnaire. As you can see, people with night pain, their disability went down, but then it kind of evened out with the sham treatment. The people without night pain, you can see their disability kept dropping all the way till 2 months post-study. This one kind of evened out with the sham. So they also had evaluations with VAS and CS. So VAS is a visual analog scale we've already talked about. The CS is the constant Murley scale. The constant Murley scale is a pretty holistic approach. It's a 100-point scale. They test pain, impairment, strength, range of motion. So it's using goniometry as well as subjective data. So that's a really good evaluation for the whole patient, like everything about their impairment and how it's affecting them. So the takeaway for this study was that shortwave diathermy for night pain negative, so people without night pain, had clear benefits. And in the study, they stated that shortwave diathermy may provide long-term benefits in night pain negative patients whose pain does not have an inflammatory character. These outcomes emphasize the importance of identifying night pain symptoms in shoulder or subacromial impingement syndrome. They did cite bursitis and tendonitis as possible culprits for causing the pain or the lack of good benefit from the shortwave diathermy in those night pain positive patients. Perhaps that inflammation, obviously, it would not respond well to a deep heating agent because this was set to continuous as well. So this is just an overview of that. So overall, they saw improvement in all, like if you put all the groups together, there was clear improvement in everything. However, the night pain negative had 1, 2, 3, 4, 5 clear improvements in the CS, the VAS, and the SDQ. And then the significant difference was only in the VAS, so the pain scale for night pain scores, that was significant for one of the evaluations 1 month post-study for the night pain positive. So it's clear that there's a lot more improvement in the night pain negative group. So this study had limitations. It was a pretty small sample size. It did not use MRI analysis to look at the improvements image-wise after the study, and then they didn't look at acromial morphology, so if they had a hooked acromion, they didn't know that, and they didn't incorporate that into the study. And there were no conflicts of interest in this study reported. Finally, the last research I did was looking at shortwave diathermy genotoxic effects in patients with knee osteoarthritis. I'm just going to go through this one really quick, just to kind of give you a feel of what it was about. I did this study because I was interested in the safety of shortwave diathermy, so even though it was not a randomized study, it was pretty well done and clear of what they did. So it was a clinical study. They followed this Declaration of Helsinki is about ethics, so it's about doing clinical trials and being ethical. So they picked 30 consecutive patients who met the criteria of ACR, which is the American College of Radiology diagnosis criteria for osteoarthritis in the knee. It was a 2-week study, 5 sessions per week, and there were 30 participants. In the end, so here's the criteria. That's the one I told you about, the ACR knee osteoarthritis diagnosis criteria, and then they couldn't be doing any of these things: smoking, alcohol use, viral illness, medical, radio, or chemotherapy, ultrasound, x-ray, MRI, and short-wave diathermy. The results basically showed that there was no statistical significance that was showing that there was any danger in using short-wave diathermy. It wasn't going to be causing any genotoxic effects on a person. However, there are legitimate concerns for people who are pregnant, which is why the contraindications are to be taken seriously and to be implemented. The way they did this, they drew venous blood samples before and after the shortwave diathermy treatment, and they looked for multinuclei formation, which means that it's the beginning of genotoxic effects. It's the beginning of genomic instabilities and the formation of tumors. And there was not a significant difference before and after treatment, meaning the uptick wasn't statistically significant. So there is no evidence to say that shortwave diathermy is unsafe for people to use. However, it does support the contraindications that are already in existence today. The limitations is there was no random selection of participants. However, the people were blinded to the drawing of the blood. They were blinded whether they received sham or real diathermy treatment. These are all the references, and that's the end.